Dr. Shanmugavelu, for your kind words. The topic to be discussed today is, I thank Dr. Shanmugavelu. I also thank Dr. JVK for giving me an opportunity to talk to you about the consequence of diabesity. We'll just have an introduction, which I may have a little overlap with the previous speaker. The term diabesity is coined by Sims to describe the strong pathophysiology link between the diabetes and excess body fat, which is in 1973. The patients with diabesity have a 7-fold increase in mortality when compared to healthy individuals. This is very important, and there is a huge economical burden on diabesity in the real impact of world economy, which is about 15% of the country total health expense in managing the diabetes, obesity, and the complications, so on. And we see there is a huge rise in incidence of both the obesity and diabetes. Since 1994, the obesity was about 20%, and now it is 40% in 2018, and so as the diabetes also increased from 8% to 14.5% now. So the obesity is the major risk factor, and the prevalence is about 40% in India, and southern it's much more than the East world, and hence the diabesity is a 21st century epidemic as per WHO, and the definition is diabesity is combination of type 2 diabetic and obesity with or without associated risk factors such as dyslipidemia and hypertension. So here we see each 1 kg increase in body weight increases the risk of diabetes about 4.5%. Here we see the pathophysiological, which has been already discussed by Dr. Chandrasekhar. In short, the genetic factors plus unhealthy lifestyle play a significant role in development of diabesity. The key pathophysiological process is the development of insulin resistance. Already it's been discussed. We see the injured adipocytes secrete a variety of pro-inflammatory markers, substances which lead to systemic inflammation resulting in oxidative stress in adipocyte, and is associated with lower adiponectin secretion that is linked to the glucose regulation and metabolic syndrome. We also see the excess fatty acid in circulation due to high fat diet resulting in chronic inflammation and oxidative stress, and the TGL accumulation in liver and skeletal muscle promote insulin resistance, which has been already discussed. We also see the mitochondrial dysfunction which happens, and altered gut microbiome, which has already been discussed. So now coming to the complication of diabetes, diabesity. It involves various cardiovascular system resulting with atherosclerosis, hypertension, atrial fibrillation, and heart failure. In gastrointestinal system, we see the gastroesophageal reflux and inflammatory bowel disease, and of course the microbiomes has been already discussed. And in reproductive disease system, we see the male infertility, female infertility with PCOS, and in musculoskeletal we see osteoarthrosis and fatigue and back pain. In metabolic, we will see the fatty liver disease, dyslipidemia, and gallstone disease and gout. And it also involves CNS with resulting with depression and anxiety and coagulation abnormality and obstructive sleep apnea, and a few cancers about which we'll see in the future slide. The consequence of diabesity is discussed here in this slide, which is there is an insulin resistance, metabolic syndrome, macrovascular complication, and MAFLD, OSA, CKD, and CVD, stroke, and depression, heart failure, and cancer, and so on, about which we'll be seeing subsequently. The metabolic syndrome, the rising prevalence of abdominal obesity has direct correlation with increasing prevalence of hypertension and dyslipidemia. In 1998, Dr. Vaughan defined metabolic syndrome as a coronary risk factor, and is characterized by a cluster of all these factors: obesity, IGT, elevation of TGL, and reduced HDL, and hypertension. And the persons with metabolic syndrome are at risk of developing type 2 diabetes and cardiovascular disease. And when it comes to the microvascular complication, the association between the obesity and retinopathy is strong in type 1 diabetic. The association between obesity and neuropathy is strong in type 2 diabetic, and the incidence of nephropathy was much higher among patients with type 2 diabetic compared to non-obese diabetic. Coming to an important area, which is MAFLD, that is metabolic associated fatty liver disease. And we see the metabolic dysfunction and inflammatory process in obesity and type 2 diabetic have closely associated with the NAFLD, which was the old terminology. Now it has been modified to this MAFLD, and it is directly associated with increased CV mortality in diabetic patients. And MAFLD may be one of the early end organ complication in type 2 diabetic and metabolic syndrome. Hence, early identification and management of this may have significance in preventing the mortality and morbidity. Coming to the obstructive sleep apnea and hypoxia, they have been linked to alteration in the adipokinase levels as well as oxidative stress. All in turn lead to accumulation of excess adipose tissue and development of insulin resistant. And sleep apnea and type 2 diabetic both have been associated with increased CV mortality and morbidity. Hence, the combination two may have proven detrimental in most of the situations. Now, the CKD, the development of diabetic kidney disease, may have mitigated through insulin resistant. We know insulin is essential for normal glomerular function and podocyte, and dysfunctional insulin signaling have been shown to dysregulate vascular endothelial growth factor. Studies have demonstrated podocyte damage and glomerular sclerosis and albuminuria occur in patients with insulin-resistant excess amount of glucose and fatty acid and amino acid present in the proximal convoluted tubule due to high fiber diet, high fat diet, and obesity and of diabetes will cause dysregulation of relevant pathways that are normally protecting the kidney, consequently resulting in the tubular injury presenting with fibrosis and inflammation. Coming to the mechanism of developing hypertension in diabesity, there is a sympathetic overdrive in majority of the individual and stimulation of the RAS. Both contribute in increasing the incidence of hypertension in diabesity. And coming to the CVD, the diabetes is associated with CVD arise by variety of mechanism. Atherosclerosis is one which emerges in multiple vessels. We see it doesn't occur in local, it happens in multiple vessel beds, and also patients with diabetes are often have comorbidities such as dyslipidemia, hypertension, endothelial dysfunction, and inflammation. So diabesity, a combination of type 2 diabetic and obesity contribute to cardiac, metabolic inflammation, and neurohumoral changes that determine cardiac dysfunction. In other words, it's a diabesity related cardiomyopathy. So the other thing which already Dr. Chandrasekhar said, the epicardial adipose tissue around the myocardium promote the myocardial inflammation and the fibrosis. That is also associated with increased risk of heart failure with preserved ejection fraction, also atrial fibrillation and coronary atherosclerosis. This is the repetition of the same, and so the diabesity increases the CV mortality, all-cause mortality, non-fatal MI, and non-fatal stroke. Coming to the heart failure, it has been proposed that diabesity significantly contributes to endothelial damage and heart failure, which are both exacerbated by the dyslipidemia. And diabesity have different effects on mitochondrial functions in cardiac muscle, and hence diabesity may have a direct link to structural alterations and stress of cardiac muscle leading to heart failure. So now coming to the stroke incidence, obesity increases the risk of stroke by several distinct mechanisms, including we see most of the obese patients have diabetes mellitus, hypertension, atherosclerotic episodes, and atrial fibrillation with embolization and obstructive sleep apnea. The end result may progress to atherosclerosis and thromboembolism that may result in arterial occlusion or rupture. For every 1 unit increase in BMI, the risk of ischemic stroke increases by 5%, and the risk of ischemic stroke was higher in obese diabetic patients compared to overweight or normal weight individual. However, the risk of hemorrhagic stroke is higher in slim person when compared to overweight or obese individuals. So coming to the CNS effect, the dementia, the diabetes and obesity can lead to accumulation of amyloid plaques through several pathways, including insulin-resistant hyperglycemia, hyperinsulinemia, and chronic inflammation, resulting with oxidative stress and vascular impairment. And the Alzheimer's disease, it is otherwise called type 3 diabetic or brain diabetic, display a characteristic cognitive decline due to amyloid plaque and neural necrosis. the key mediator of the disease progression is the insulin resistance within the brain. So obesity, diabetes, Alzheimer's disease contribute to common inflammatory process. This is what here we see in the right chart. The type 2 diabetic, obesity and Alzheimer's disease, they have the common pathway and the chart. Coming to the other episode, the depression is twice as common in subject with type 2 diabetic compared to normal glycemic subjects. The neurobiological mechanism for the association between the depression and type 2 diabetic include: one, alterations involved in the metabolism of serotonin and norepinephrine from the adrenal pituitary hypothalamic axis, and the tropic agents are the brain derived neurotropic factors through glycogen synthesis kinase, that is GSK. So it is possible that an overactive activation of the GSK3 play an important role in the pathogenesis of development of schizophrenia and some individual and mood disorders such as bipolar disorders and major depression in patients with type 2 diabetics. So the presence of metabolic alteration in type 2 diabetic patients such as obesity increases the severity of the depression. Coming to the incidence of cancer, many observational studies suggest that obesity and diabetes are associated with increased risk of developing several types of cancers, including liver, pancreatic, endometrial, colorectal, and in postmenopausal women, the breast cancer. And the other the consequence is the mechanical, the osteoarthrosis. The individuals with type 2 diabetic are more susceptible to develop osteoarthrosis. This is particularly explained by shared factors for these conditions such as aging, obesity, and inflammation. The aging and obesity related physical and psychological physiological impairment contributing to the development of OA, that is we are presenting with the muscle weakness, pain, atrophy, and poor balance, and the hyperglycemia may also directly injure the cartilage health of the knee joint by mechanism involving the AGE and peripheral neuropathy. So the association between the OA and the weight stronger in women than men. The diabetes is associated with increased pain sensitivity and decreased walking speed in patients with OA. And diabetes was linked to pain in erosive hand OA in either type 1 and type 2 diabetic, indicating the low-grade inflammation also contribute in this condition, and obesity might be linked to OA owing to the effects of weight and misalignment on joint, especially weight-bearing joints that after joint cartilage. Now coming to the elderly, it is that there is a structural and metabolic endocrine and adiposity changes in type 2 diabetic and aging, which is seen in the chart. And now coming to an important topic, diabesity in hypertension, diabesity in pregnancy. The hypertensive disorder of pregnancy, the gestational hypertension and preeclampsia are associated with an increased risk of maternal and fetal complication, including preterm labor, small for gestational age, and C-section delivery. And the large for gestational age, a dose-dependent relationship exists between the obesity and the rate of large for gestational age in women with GDM or type 2 diabetic. The fetal abnormality, the screening normally which we do, the screening in obese individual during pregnancy is very challenging, and excess abdominal fat reduces the accuracy of detecting rates of abnormality, and even fetal monitoring during labor is more difficult. And unexpected intrauterine fetal death and perinatal mortality is also seen, and increased likelihood of need for delivery by cesarean section is also seen. So and fetus with of women with diabetes are at increased risk of congenital malformation if it is not controlled, especially with the cardiovascular and fetal microsomia and intrauterine fetal death. And obesity and diabetes are associated with several congenital malformation. These malformations include neural tube defects and heart defects and orofacial defects, and of course the maternal and fetal complications, which we all know about it. And coming to the infertility, the female infertility happens because of obesity with PCOS, and in male the serum level of total testosterone and sex hormones binding globulin were significantly lower in men with obesity and diabetes. And the type 2 diabetic men with low testosterone level have high prevalence of symptoms suggestive of hypogonadism, such as fertility and erectile dysfunction, and there are multiple pathways which are involved, and the obesity and type diabetes are associated with reduced semen volume, reduced sperm count, and reduced sperm concentration, and decreased testosterone level, resulting in low libido and erectile dysfunction as well. Ejaculatory defects can happen due to the neuropathy. So the high BMI, that is more than 30, are associated with a decrease in sperm concentration and sperm count compared to low BMI. And the one of the reason for that is the optimal temperature for sperm growth. We all know it is 34 to 35 degree. In obese patients, the local temperature of the scrotum can increase due to thickened scrotal fat and semen. So this is about diabesity in children. We know it is a common feature which we are seeing in our practice due to excessive eating and lack of exercise by children, and has got similar difficulty. And now coming to the increased drug requirement in diabesity, the patients with diabetes are on the polypharmacy. They take more medications and yet have a poor BP and lipid like glucose control, and there is a high prevalence of microvascular disease. So the impact of diabesity is not only the individual patient, also the family, the healthcare system, and the economy. And to summarize, it is an epidemic in worldwide, and if there is a early detection of effects of diabesity, can help the management and strategy optimizing the implementation of effective treatment and appropriate method of management using dietary therapy, physical activity, metformin, newer OAD, and GLP receptor. We are waiting for the next speaker to deliver. Thank you so much.
Thank you, Dr. Natarajan. You have covered nicely. So diabetes is a